We will go for the next speaker. It's my pleasure to introduce Professor Dr. Ahmed Magdy Moustafa, Medical Military Academy. Dr. Ahmed will give us a talk about the hypertension and its role now in what's called ischemia with non-obstructive coronary artery disease or INOCA. دكتور احمد.
كل الشكر دكتور محمد، كل الشكر لاساتذتي جمعيه الضغط المصريه على الدعوه الكريمه. بسم الله الرحمن الرحيم. Our talk will be on hypertension and ischemia with non-obstructive coronary artery disease. All of us know that ischemic heart disease continues to represent a major health threat to death, disability, and poor quality of life, and also it consumes enormous health-related resources. For over a century, the major clinical phenotype was taken to be the obstructive coronary artery disease or obstructive atherosclerosis. الحقيقة in the past years we are knowing new terms about ischemic heart disease. The new term is open artery ischemia. What is meant by new term open artery ischemia? It's a large phenotype that have angina with no obstructive coronary artery disease, ischemia with no obstructive coronary artery disease, and myocardial infarction with no obstructive coronary artery disease. How can we diagnose these types? First of all, we are asking about the symptoms of myocardial ischemia, either with effort or at rest, or is it exertional dyspnea. We can investigate the absence of obstructive coronary artery disease with the definition of less than 50% diameter reduction or FFR more than 80. And these are diagnosed either with CT coronary angiography or the gold standard invasive coronary angio. The objective evidence of myocardial ischemia in the presence of reversible defect, abnormality, or flow reserve on unfunctional أو imaging test زي الستريس تيست أو المسح الذري. Again, the fourth step in the diagnosis of the criteria of microvascular angina are the evidence of impaired coronary microvascular function. The diagnosis of MI with non-obstructive coronary artery disease, which is the term INOCA, it depends on ECG criteria, ST elevation or troponin rise, in the presence of non-obstructive coronary artery disease, either normal or mild coronary artery disease, with no apparent cause for presentation. What are the mechanisms of myocardial ischemia? Myocardial ischemia result from multiple mechanisms like coronary stenosis, microvascular dysfunction, vascular spasm, myocardial bridging, primary metabolic abnormality, the inflammatory theory, systemic inflammation and autoimmune disease, and platelet aggregation and coagulation. Regarding ischemia with non-obstructive coronary artery disease, it results from two major mechanisms, either coronary microvascular dysfunction or vasospastic angina. The coronary microvascular dysfunction, it results from multiple risk factors. The traditional risk factors like smoking, hypertension, it's more common in female gender, in blood disease, in obesity. The vasospastic angina, it results from either transient vasospasm or persistent vasospasm. In comparison to the ischemia with obstructive coronary artery disease, which is the traditional ischemic heart disease, that result from either a stable plaque in the chronic coronary syndrome or unstable plaque, which is vulnerable plaque that may result in acute coronary syndrome. The risk factors in the INOCA versus the obstructive coronary artery disease are also the same, but the prevalence is different. Here we can appreciate that in women, the female sex are more common for ischemia with non-obstructive coronary artery disease. The dyslipidemia is more common in obstructive coronary artery disease, while hypertension is more evident and more common in patients with non-obstructive coronary artery disease. Again, multiple mechanisms for myocardial ischemia, either, as we said, the coronary microvascular dysfunction, the vasospasm, and the altered coagulation. The microvascular dysfunction is not a cardiovascular disease alone, it's a systemic disease. Here we can appreciate that microvascular dysfunction may result in lacunar stroke, in vascular dementia and amyloid angiopathy in the form at the level of the brain. At the level of the eye, it can result in retinopathy. At the level of the kidney, it results in nephropathy. It results in primary arterial hypertension. And as we said, in the cardiovascular system, we can appreciate angina with non-obstructive coronary artery disease, or INOCA, or HFpEF. How can arterial hypertension be a cause for open artery ischemia? There is a coronary microcirculation dysfunction that occurs during hypertension on multi-levels. First of all, the structural mechanisms, it results in capillary rarefaction, arteriolar wall thickening, perivascular fibrosis, conduit vessel stiffening, intravascular microplugging. On the myocardial mechanisms, we can appreciate left ventricular hypertrophy, infiltration, calcium overload, extramural compression, and increased diastolic pressure. On the functional mechanisms, we can appreciate endothelial and vascular smooth muscle cell dysfunction, the regular atherosclerotic risk factors, the drugs and the spasms that can occur in the coronaries. On the systemic mechanism, we can appreciate reduction in the diastolic pressure time, anemia, hypoxia, and glycemia. All these factors can result, and the net result of all these factors with the coronary macrocirculation result in ischemia with non-obstructive coronary artery disease. Regarding the presence of minor plaque that can be appreciated in the intravascular imaging, like this crescent plaque that is present in one of the vessels, LAD, although it is non-significant in the IVUS and it is not seen in the coronary angio, invasive coronary angio, the presence of arterial hypertension can disrupt this plaque and cause acute coronary syndrome or non-obstructive coronary artery disease. So the plaque disruption is followed by local thrombosis and then fibrolysis, which may result in distal embolization. Arterial hypertension is a major contributing factor for plaque rupture. Angiographic image may suggest the plaque rupture, but final diagnosis can be made using either IVUS or OCT that can be more accurate than the invasive coronary angio. The second most common mechanism is the spontaneous coronary artery dissection. The arterial hypertension may be a risk factor for spontaneous coronary artery dissection that is very evident in the female. And the spontaneous coronary artery dissection, although it is a rare mechanism for INOCA, but it is not rarely observed as a cause of acute coronary syndrome. It results from the tearing pressure on the intimal layer that may result in intimal tear and coagulation cascade that result in acute coronary syndrome. In the case of coronary microvascular dysfunction, there is a remodeling of the small arteries and arterioles. The hypertension results in hyperplasia and the hypertrophy that change the smooth muscle system, causing narrowing of the vessel lumen, which result in the reduction of coronary reserve with clinically manifested angina. Also, the microcirculatory spasm may be the end result of the coronary microvascular dysfunction. This is an algorithm on how to diagnose. First, patient evaluation. Then we can do non-invasive assessment if there is normal ECG, normal enzymes. We can do coronary CT angio to prove or to decline the presence of coronary artery disease. After we confirm the presence of patent coronary artery disease, we can go for invasive assessment, for functional assessment like stress test or stress MPI to prove the presence of ischemia. And then we can appreciate the diagnosis of invasive ischemia with non-obstructive coronary artery disease. الحقيقه مش دايما بنلاقي العيان نورمال، ممكن نلاقي العيان نورمال، ممكن نلاقي العيان عنده mild coronary artery disease اقل من 50% او moderate 50 to 80% lesion. In these types of lesions that can we appreciate presence of coronary artery disease, we can do FFR, coronary flow reserve. In the presence of FFR more than 0.8, coronary flow reserve more than 2, so no coronary microvascular dysfunction can be present. In the presence of FFR more than 8, but coronary flow reserve less than 2, the coronary microvascular dysfunction is proved. Then we can do vasoreactivity test, either acetylcholine test or something else, to prove the presence of vasospastic angina. How can we manage the cases of non-obstructive ischemia with non-obstructive cardiovascular disease? First of all, lifestyle change in the form of healthy diet, in the form of exercise, in the form of weight management, smoking cessation, and coping with the stress. Regarding the risk factor management, the first of all is to control the blood pressure. And the control of blood pressure can reduce either the symptoms of ischemia or the incidence of acute coronary syndromes. Regarding the other risk factor modification, the dyslipidemia management and diabetes management. Regarding the anti-anginal medication, we can use, in the case of microvascular angina, we can use beta blocker, calcium channel blocker, nicorandil, ranolazine, ivabradine, and trimetazidine. And we can consider statin ACE or ARB in the presence of dyslipidemia. In the case of vasospastic angina, we can use calcium channel blocker or long-acting nitrates and nicorandil. The latest recommendation of the hypertension guidelines is stated in a class 2B recommendation that hypertension and left ventricular hypertrophy is frequently associated with myocardial ischemia with non-obstructive coronary artery disease, including patient with INOCA. And the treatment with RAS inhibitors, beta blocker, and calcium channel blocker can be used in this condition. As we mentioned, microvascular angina are treated with beta blocker, calcium channel, ranolazine, trimetazidine. The main mechanism of action is depending on the escalation of microvascular function and restoration of the microvascular function, decrease the myocardial oxygen consumption, the antioxidant properties, the vascular smooth muscle relaxation, and decrease myocardial oxygen consumption with improvement of microvascular perfusion. In the case of vasospastic angina, the first choice is calcium channel blocker, amlodipine or verapamil or diltiazem, the use of nitrates, and especially long-acting nitrates and nicorandil, and all these mechanisms improve the small vessel remodeling, decrease the oxygen consumption, and increase smooth muscle relaxation. In the presence of combination of microvascular angiopathy and vasospastic angina, also the use of trimetazidine, ACE inhibitor or ARB, and the statin may improve the condition. It's a new area of research because we have still some gaps in knowledge, like we are lacking large studies for the prevalence of INOCA. We have few studies evaluating the pathophysiology, few studies to evaluate the microvascular dysfunction. Still, we have few studies for non-invasive techniques to diagnose the non-obstructive coronary artery disease. We have lacking of studies evaluating the cost effectiveness of diagnostic approaches. Few studies on lifestyle intervention and how can it affect the patient with non-obstructive coronary artery disease, the prevalence of INOCA among women with the prior history of pregnancy-related conditions, and it is not sufficiently studied. Thank you.
شكرا دكتور احمد. فلور، حد عايز يسال اسئله؟ اتفضل. فيري شورت كويشن بعد اذنك، معلش.
أنا طبعا بشكر الدكتور أحمد على المحاضرة دي، محاضرة جميلة جدا يعني، وخاصة الانجيوباثيز. أنا كان طول عمري بقول انجيوباثيز it will affect all the arteriolar tree. لو لقينا انجيوباثيز في الفندل اكزامينيشن يبقى لازم ندور على انجيوباثيز في كل حتة تانية في الجسم، خاصة سب اندوكارديال انجيوباثيز، ودوت اللي بيفسر لنا الاكيوت سادن ديث اوف اثليتس. اللي هو النون اسكيميك او النون اوبستراكتيف كورونري ارت ديزيز، واللي هو سب اندوكارديال اسكيميا يعني نتيجه المايكروفاسكولار يعني. بس انا ايضا عايز ااكد هنا ان لو في حالات مشتبه فيها كده لازم لو عايزين نبتدي تريتمنت اي ثينك اتس بيست تريتمنت اللي هو الكارديو بروتكتيف elements like trimetazidine like الرينكس الحديثه
الايس والاي ار بيز.
ولا ايه راي حضرتك؟
الايس والاي ار بيز. الايس والاي ار بيز
ده لو معاه هايبرتنشن.
يس.
لكن لو نورموتنسيف يبقى في المايكروفاسكولار نبتدي بالترايميتازيدين ولا؟ شكرا
شكرا دكتور احمد.
شكرا دكتور.